An ultrasound machine, a portal ultrasound machine is 5,000 euros. It's not so, and also an portable ultrasound machine is not so expensive. And peer teaching, train the students to train their colleagues, could be a solution to the lack of personnel.
The model, Germanic model or Austrian model with tutor, student tutor, I believe is a good one, but for this, they must be trained very early. Otherwise, if they are trained in 5th year, they will lose very, very soon. Okay, and maybe we try to push a little our university to buy more machine, because there are few machines, but I believe nowhere there are 15 or 20 machines that are necessary for a good training for the student. Okay, thank you very much, Roxana. And we go further. But if you have questions later on, you can address these in the chat of the meeting. Okay, and it's my pleasure now to introduce next speaker. That is Quan Nguyen from Center of Education Vietnam. He's very active in this activity and with a lot of meetings and coordinator of many meetings. And I have the pleasure to introduce with an interesting topic for me too, error and pitfall in shear wave elastography of the liver. Please, Quan.
Yes, can you hear me?
Yes, we hear you.
Yes. First of all, I would like to organizer to invite me to be here to share my knowledge. It is a great honor for me to be here. Now, today, I would like to present my topic, errors and pitfalls in the shear wave elastography of the liver. This is the purpose and the outline of my talk. As you know, chronic liver disease include chronic hepatitis B, C, alcohol liver disease, metabolized dysfunction associated steatosis liver disease, and steatosis hepatitis, and autoimmune hepatitis, etc. These chronic liver disease can cause the liver progress to the fibrosis, and eventually the liver becomes cirrhosis. Thus, liver function decrease and clinical significance, portal hypertension, and HCC, hepatocellular carcinoma formation as well. What is the liver fibrosis? Liver fibrosis is a response of the liver parenchyma to chronic inflammation lesions. That is the consequence of the imbalance between the process of formation and degradation of collagen and protein glycans components in the liver. So cirrhosis is the final stage of the liver fibrosis. The roles of the assessment of liver fibrosis. Liver fibrosis measurement is very important because as many guidelines of race organized in the global recommend us we have to know the liver fibrosis before we start the treatment for the patient chronic liver disease. And liver fibrosis help us to make decision of treatment. And liver disease help to assess the response of the treatment and follow up the disease. And liver fibrosis contribute to the prediction and complication and prognosis of disease as well. Nowadays, ultrasound shear wave elastography is the best choice for measurement of liver stiffness. But we should pay attention that third liver stiffness not corresponding at all to the fibrosis. So we have to we have to be careful when we interpret the liver stiffness of the patient. There are three origins of errors when we evaluate the liver fibrosis. The first is equipment, due to equipment. As you know, we have MRIs, ultrasound, with the many kinds of hardware, software to build the silver elastography. And the second origin source of the errors is this is a technique operator dependence. It's a dependent experience and skill of the operator. And the third is is dependent on underlying disease of the patient and comorbidities disease of the patient as well. So now we first of all would like to talk about the source of errors caused by technology of equipment. Each manufacturer uses different technology to build a silver elastography. So that's why we have some error when we take in this machine to the result of other machines. A study of primary, in the study, he showed us there is difference 12.7 until 70.6% of the stiffness measurement of the liver due to the difference machine and they use with the experimental with the phantom for the measurement. And another study by Dr. Grgurevic, she also proved that there is a difference 1.5 kilopascal between two machines using 2D survey and 0.79 kilopascal between the four machines using Quan survey. So that's why in the guideline of the ISUM 27, the stiffness threshold for clinical use now with equipment should not be utilized for other equipment unless we prove otherwise. This recommendation should be taken by applying not only to the equipment from different manufacturers, but even to different equipment in the same manufacturer or different settings for the same equipment. So when we use the silver elastography, we have to use the stiffness threshold provided from manufacturer in the machine. And now we talk about the error from the due to the skill experience of operator. Generally speaking, expert operators' reproducibility of the measurement is better than novice operators. This slide, I would like to talk some common errors due to the technique of the operator. The errors are due to fasting, not correct fasting, not correct breathing, not correct position of the FOV, due to preparation phenomenon and phenomenon of strike pattern. Due to the blood vessel present in the FOV box. In this image, in this slide, two images, it belongs to one person. The left side, the image take the silver elastography before a meal, and we get 1.24 meters per second. But in the right side, after the meal, we redo silver elastography, and the result is 1.46 meters per second. So, according to many studies, after the meal, the liver increased stiffness. So we have pay attention when we do elastography, normally we should do the segue elastography after fasting for at least 4 hours. Now another errors due to the break incorrectly in the upper image when we do the segue elastography, when the patient is sprayed maximally, we get 1.34 meters per second. But in the neutral position of the patient, we only do elastography and we get 1.17 meters per second. So a solution in this situation, we have a measure in the neutral breathing and holding breathing of the patient, not maximum expiration or aspiration. And sometimes we have to practice for the patient to breathe before we measure the segue elastography. Now we move to another errors when we do the segue elastography. Many studies prove that we should do segue elastography when we measure in the right intercostal and in the segment 7 and segment 8. Either when another segment we cannot guess the confident results. Normally we have to position the FOV in the central beam of the blob, and we should not set the position of the FOV too shallow, too deep, or out of the central beam of the blob. So even when we put the FOV in the central beam of the blob, but the FOV, the axis of the SOV is not perpendicular to the liver surface, we can get the error as well. So we have to pay attention to get the FOV in the central beam of the blob and perpendicular to the liver surface. Another errors, that is the presence of the blood vessel inside the FOV. In the video, you can see in the left side, you can see the quality map of the elastography. You can see the low quality. That's just due to the presence of the blood vessel in the FOV, and in the elasticity in which is increase the stiffness of the liver. So solution in this situation, we have a reposition of the FOV, and it should be pay attention that sometimes the blood vessel out of length, and due to slight thickness of the ultrasound, it causes the effect of partial volume. So in this image, you can see the quality map is very high, but in the elasticity map, you can see the inhomogeneous of the elasticity due to the vessel, the presence of the vessel outside the plane. So in this situation, we have to reposition of the FOV as well. General speaking, many guidelines recommend that the FOV position should be 2 centimeters below the liver surface and in the central beam of the blob, and perpendicular to the liver surface, and the focus point should be set in the same level with the FOV, and the column mapping of the FOV filling completely and homogeneous, and the size of the rod to use to measure of the elastographic velocity should be 1 centimeter, and standard deviation device means we call the coefficient of variation should be less than 0.25 for stiffness value between 8.8 and 11.9 kilopascal, and coefficient of variation should be less than 0.1 kilopascal, 1 for stiffness over 12 kilopascal. Another error of the result of elastography is that the presence of the reverberation phenomenon. In this video, you can see the phenomenon of reverberation below the liver surface. That's why it causes the low quality map, and the elasticity of the liver increase. In another patient in this situation, you can not see the artifact reverberation below the liver surface. In this situation, we have a result confidently. And another error that is the side artifacts due to the technology. Some manufacturers use a technology of multi-push pulse. In the video, you can see the multi-push pulse that some manufacturers use to build the serial elastography, and that reason in the upper image you can see the artifact stripe artifact present in the column map and in the elasticity map as well. So in this situation, we have narrowing the FOV, and we can switch to the method of Quan elastography. And in this slide, you can see the WFUMB protocol to acquisition of the liver stiffness in 2024. You can see the many recommendations. So beside the common error that I have just talked, we have to respect this protocol to get a reliable measurement of the liver shear weight. And additionally, the quality map is very important for the practice daily. We have to use the reliable or the quality map to get a good result. It's many kind of quality map of the is a different manufacturer. And how about the intra-operator and inter-operator? Dr. Perelli and some studies show yes, the intra-operator is always better than inter-operator. Yes, why? According to the ISUM, we have two learning curves for the practice. The recommend of the ISUM to increase the reliable result of the silver elastography. The practitioner must perform at least 500 abdominal examination and 50 types of abdominal silver elastography under the supervisor of experienced person. Now, I move to another cause of the error, that is the underlying disease and comorbidity disease. In the slide, in the schema, you can see liver stiffness can caused by matrix deposition, hepatic infiltration, and inflammation, and ductal pressure increase in the liver, and increase intra-abdominal pressure and venous pressure. So in the slide, you can see when the ALT increase the more than 5 times of the upper limit of normal, will increase the liver stiffness. So in the solution, in this situation, we should do a silver electro at the time of sustained virology response for the patient with chronic hepatitis B or C, and we should monitor the change over time. We call a dental change. In this case, You can see in the right side, and you can see the liver increase elasticity in when you're beginning to treatment for the patient. After 4 months of treatment, the elasticity of the liver decreased. Besides the inflammation of the liver can cause the liver increase the liver stiffness. We can have another cause, hepatic congestion, cholestasis, portohypertension, and infiltrating accumulation in the liver. In this case, in the lab image, you can see this is a patient have a right heart failure, right side heart failure, and you can see the dilatation of the hepatic veins, and the elasticity of the liver increased 2.31 meters per second. After treatment of the heart failure, we redo examination of elastography, and we can this image show the hepatic vein is not dilated, and the elasticity of the liver decreased. In this case, the patient have a suffer choledocholitis, and with you can see the dilatation of the CBD, and elasticity of the liver increase. After treatment, management of the choledocholitis, the CBD decreased the diameter, and the elasticity of the liver decreased. And another cause of error when we interpret the liver stiffness, that is the case of accumulation of the tumor cell inside the liver. The CT scan confirm the metastasis in the liver, and it causes liver stiffness increase. And now we move to error due to the comorbidities of the patient. As you know, in the chronic hepatitis, chronic liver disease often occur steatosis liver disease comorbidities. So steatosis liver disease, when with the BMI over 25 kilogram per meter square, it causes error when we do the elastography Xue-ying elastography. Due to the attenuation of the power of the push pumps and ultrasound being tracking the Xue-ying. So in this solution, in this situation, we have used a low frequency probe. For example, if we take FibroScan, we can change to the XL probe. And we would like to talk another comorbidities. That is the situation of the patient have insulin resistance. It can cause increase of the liver stiffness as well. On contrast, when the patient use the beta blocker, it can decrease the liver stiffness. So a conclusion, Xue-ying elastography by ultrasound provides information on the liver stiffness correlated with the fibrosis, not direct information on the fibrotic tissue, and does not provide information on the degree of inflammation. The result of this liver stiffness measurement are affected by three main sources, with my error or test when we interpret liver fibrosis. The error due to difference in the technology of ultrasound machine. So we have to use the table of the curve-top machine. The error due to the technique of operator. We have to learning curves for the practice. And the more important, yes, and it's necessary to have sufficient knowledge and understanding of the patient pathology condition in interpreting the result of liver fibrosis. that is the final of my talks. I would like to have some minutes to talk about introduce the APSUM 2026 will be organized in the Da Nang, Vietnam, in 12 and 14 in the 2026 conjunction with the National Congress of the Vietnam Society Ultrasound Medicine. We would like to announce and to invite all of you to participate in this congress. Thank you for your attention.
Thank you very much. Very nice and comprehensive presentation. I have only one comment here. We are very lucky now that we have now the rule of 4 for RF technology. Then we don't keep in mind so many value like in previous time when for every machine we have different cutoff value. Now with rule of 5 of 4 that we use for RT technology is much easier to keep in mind this number 5, 9, 13, 17, 21. Okay, because it's the time is running, I'd like to thank you, and it's my pleasure now to introduce the new speaker. Then it's Professor Ivica Grgurevic, that is Professor of Gastroenterology, Head of Department of Gastroenterology and Hepatology and Nutrition from Zagreb, Croatia. And the presentation will be about something that Ivica worked a lot in the last years, and is ultrasound elastography for the stratification of risk of chronic liver diseases. Ivica is director of Center of co-director of Center of Education from Zagreb. Please, Ivica.
Hello, thank you, Ioan, for your introduction, and it is great pleasure and honor to participate in this great meeting. And as you have heard, the topic of my presentation will be somehow connected to the previous one, and we continue with the clinical application of ultrasound elastography for stratification of the risk in chronic liver disease. These are my disclosures, and this is the talk outline in which I will go briefly through the basic aspects of elastography, and then go to the clinical application of ultrasound and elastography in chronic liver disease, starting from the assessment of liver fibrosis, the presence of portal hypertension and esophageal varices, and then finally with the prognostication of the clinical outcomes by using elastography. And when we talk about elastography, you have heard a bit of this in the previous presentation. Basically, elastography relies on the principle that it measures the velocity of the shear waves that are generated within the tissue. If you look on the liver, these shear waves in the liver tissue are generated by the external mechanical source. Either it is a mechanical vibrator such as the one that is available in the fibroscan, or it is an ultrasound probe which produces empowered acoustic impulse. Both mechanical impulses are transmitted into the liver, and during their spread through the liver, during their way through the liver, they make small displacements of the liver tissue, and they produce so-called shear waves. And then the same ultrasound probe measures the velocity of these shear waves in the tissue. So if the tissue of the liver, or if the liver is diseased, then liver becomes stiff because of the accumulation of liver fibrosis, and in stiff tissue, these shear waves travel faster. Whereas if the liver is healthy, then liver is soft, there is lack of fibrosis, and then these shear waves travel with a smaller velocity. And if you introduce the velocity of the shear waves into the formula of Young module of elasticity, the final result of the liver stiffness will be expressed in the kilopascals or in meters per second, corresponding to the liver stiffness, which is related to the amount of the liver fibrosis. And when we talk about elastography methods that are nowadays in use in clinical practice for the assessment of liver stiffness, then these methods can be divided into transient elastography, which uses external mechanical vibrator, which is monodimensional method, which does not allow for the morphological assessment of the liver and other abdominal organs. It just gives you a number of the liver or spleen stiffness. What you can see on the display of your machine is the spreading, the way how the elastic wave spreads through the liver. On the other hand, there are elastography methods that are integrated within the ultrasound machine that allows for both morphological assessment of the organs and also elastographic assessment of the organs of interest, for example, liver and spleen. And then this depends on how do you measure the stiffness. If it is measured in a small box like here, where you do not see the elasticity map, then it is called point shear wave elastography. And in case of two-dimensional shear wave elastography, the region of interest is much larger. It is superimposed over the liver or over the spleen, and the elasticity is displayed in real time. So in theory, these 2D shear wave elastography methods might be seen as more reliable because you have visual control of the quality of the elastogram, whereas point shear wave elastography is easier to perform. And finally, whichever elastography method we use, finally the result is expressed in kilopascals, and it corresponds to the amount of liver fibrosis. So clearly on this diagram, you see that the elasticity of liver or stiffness of the liver is increased as the fibrosis stage or fibrosis quantity in the liver increases. And one additional thing which is important to appreciate from this diagram is that elastography best discriminates the patients according to the presence or absence of liver cirrhosis, whereas it is not that precise in separating between the adjacent stage of non-cirrhotic fibrotic chronic liver disease. But as you have heard in the previous presentation, not only amount of fibrosis influence the final result of liver stiffness measurement, it is also influenced by other confounders like the position of some other materials like amyloidosis, infiltration by tumors, and some other things. So it is very important when interpreting the results of liver stiffness measurement to be aware of all these confounding factors in order not to overestimate the presence of liver fibrosis. As the liver disease progress and as liver fibrosis progress, it poses more resistance to the portal blood flow to the liver, and then it comes to the development of portal hypertension, leading to increase pressure within the portal vein. So in the first part of the portal hypertension, it is clearly dependent on the amount of the liver fibrosis, and therefore portal hypertension, the presence of portal hypertension might be assessed by measuring liver stiffness. However, as portal hypertension increases, it becomes more and more influenced by hemodynamic factors, meaning more by inflow of the visceral blood flow into the portal vein, and this cannot be captured by measuring only liver stiffness. In this condition, for these more advanced stages of portal hypertension, measuring spleen stiffness might be more legitimate target because spleen reflects everything what is going on in the portal system. So in the portal hypertension, spleen becomes enlarged and stiffer, and therefore it is possible to assess the presence of the portal hypertension by measuring spleen stiffness. So now moving to the clinical use of these elastography methods in hepatology. First of all, as I already said, it is to assess the non-invasively assess the fibrosis stage instead of using liver biopsy in all patients, and then to assess the presence of clinically significant portal hypertension, esophageal viruses, and the prognostication of clinical outcomes. So I will start with the assessment of liver fibrosis and cirrhosis, and in a real-world clinical scenario, usually when we have a patient with chronic liver disease, usually these patients undergo ultrasound examination, and then it is most important to address whether the patient has or do not have liver cirrhosis. And using the classical B-mode ultrasound, it is pretty in most cases, it's pretty easy to assess the presence of cirrhosis. If you see the nodularity of the liver surface, if you see the coarse liver parenchyma and irregular interface of the hepatic veins, these are typical signs of the presence of liver cirrhosis. However, What we know from the studies is that ultrasound, unfortunately, is not sensitive enough to detect the cirrhosis in its early stages. So if you focus on child PUA cirrhosis or compensated cirrhosis, then the sensitivity of ultrasound, but not only ultrasound, but also for CT, is only around 60%. Okay, so it is not really good for these early stages of cirrhosis. So if you don't see these typical morphological signs of liver cirrhosis, you cannot rule it out in these early stages. And therefore, we need elastography. And among many elastography methods, the best evaluated method is transient elastography. And now we have many studies with tens of thousands of patients who were evaluated by this method. And in this systematic analysis, you can see the diagnostic performance of transient elastography for staging, for diagnosing liver fibrosis and cirrhosis. And as you can see, diagnostic performance as demonstrated by the area under the receiver operating characteristic curves is the very high, very good for diagnosing liver cirrhosis. It is also good, but not that good, but still also good and acceptable for diagnosing also significant and advanced fibrosis. Later on, with time, with use of more and more of these elastographic non-invasive methods, it became clear that there is a group of patients, not only cirrhotic patients, but also the patients with advanced fibrosis, which are also endangered of the development of the complications of chronic liver disease, especially development of portal hypertension, which starts to develop at F3 stage of liver fibrosis. And therefore, Baveno consensus recommended to use a new term called compensated advanced chronic liver disease that encompass both advanced fibrosis and cirrhosis, so F3 and F4 stages of liver fibrosis. And it is possible to clearly recognize or rule out these two stages by using elastography. And they issued the non-invasive criteria to diagnose compensated advanced chronic liver disease by using transient elastography. And accordingly, if liver stiffness is below 10 kilopascals, compensated advanced chronic liver disease could be ruled out. If it is over 15 kilopascals, it can be safely ruled in, whereas it is in between these values, so between 10 and 15 kilopascals, compensated advanced chronic liver disease, so F3 or F4 fibrosis are possible, but this is gray zone and usually require another test to confirm the presence or absence of advanced fibrosis or cirrhosis. Either it is another non-invasive test or liver biopsies if clinically indicated. So the practical consequences of applying these criteria is that patients who are diagnosed with compensated advanced chronic liver disease should undergo screening for portal hypertension and esophageal varices and hepatocellular carcinoma, especially if they have liver cirrhosis. So moving to further to more advanced stages of liver disease, to complications like portal hypertension and esophageal varices. And we know that if we want to assess for the presence of portal hypertension and to grade the severity of portal hypertension, then the gold standard method is invasive method of catheterization of hepatic veins and measuring the pressures within the hepatic veins. So it is hepatic vein pressure gradient. And we know that the numerical value of HVPG is clearly associated with a different risk of developing complications from a chronic liver disease. It is very important to remember the number of 10 millimeters of mercury of HVPG because it denotes the clinical presence of clinically significant portal hypertension. Because from this stage on, all other complications of portal hypertension develop, including formation of esophageal varices, ascites, encephalopathy, and risk of dying. So it is the most important threshold in this situation. And it was shown now many years ago by Italian group of authors that it is possible to assess the presence of clinically significant portal hypertension by measuring liver stiffness by transient elastography. In this study, you can clearly see there is a good correlation between the liver stiffness and HVPG as measured invasively. However, if you focus more deeply in this diagram, you will clearly see there are two parts of this diagram. One part up to 10 or 12 millimeters of mercury, where the correlation between the liver stiffness and HVPG is very strong, very tight, whereas over the 12 millimeters of mercury, there is still correlation, but it is much weaker and barely significant. Why? Because, as I already pointed out, in the early stage of portal hypertension development, it is mostly influenced by the liver stiffness, by the accumulation of fibrosis, whereas in the more advanced stages, it is influenced by hemodynamic factors, which cannot be clearly captured by measuring liver stiffness. Therefore, one of the important messages is when you use liver stiffness as the measure of portal hypertension, it is best used to classify the patients according to the presence or absence of clinically significant portal hypertension, whereas it is not possible to further substage the severity of portal hypertension. Not only liver stiffness, but later on it was demonstrated that also spleen stiffness also stands in very good correlation with HVPG and even better correlation than with liver stiffness. And all these data and many other studies led finally to recommendation by Baveno Consensus that issued criteria to quantify, to assess the patient for the presence of the clinically significant portal hypertension and varices. So the presence of clinically significant portal hypertension might be assumed in patients who have liver stiffness over 25 kilopascals, provided they are not obese NAFLD patients, or they have spleen stiffness over 50 kilopascals. Clinically significant portal hypertension can be ruled out if liver stiffness is below 15 kilopascals and platelet over 150, or spleen stiffness below 21 kilopascals. And varices needing treatment or high-risk esophageal varices might be safely ruled out by these non-invasive methods, so the endoscopy is not necessary in this situation. If liver stiffness is below 20 kilopascals and platelet count are over 150, or spleen stiffness is below 40 kilopascals. So practical consequence of this is that patients who are diagnosed with clinically significant portal hypertension should receive non-selective beta blockers to prevent liver decompensation. And in patients who, in whom varices needing treatment are ruled out based on these criteria, does not really require upper GI endoscopy. So further step in this direction in the development of this area and non-invasive methods for portal hypertension comes from this study in which the combined algorithm that combines all these three categories, so liver stiffness, spleen stiffness, and platelet count, was applied. So first we have a classical Baveno model that use liver stiffness and platelet count to rule out the presence of clinically significant portal hypertension, or only liver stiffness to rule in the presence of clinically significant portal hypertension in patients with chronic liver disease, as I have pointed out in the previous slides. But applying these criteria, it is possible to correctly classify around 50% of patients according to the presence of clinically significant portal hypertension. But if we use combination of these three criteria, so liver stiffness, platelet count, and spleen stiffness measurement, and if any two out of these three are positive for ruling out and for ruling in the presence of clinically significant portal hypertension, then this cohort of patients who have undetermined results, so who remain in the gray zone between these criteria, can be shrunk to just 9%. So it is possible, by using this combination of criteria, to non-invasively assess the presence of clinically significant portal hypertension in over 90% of patients with chronic liver disease. Finally, we come to the prognostication of clinical outcomes, and it is logical and clear, I would say, that if we know that liver stiffness is the results from accumulated liver fibrosis, then the patients with increased liver stiffness should have worse prognosis in comparison to to patients with a lower liver stiffness, which was clearly demonstrated in many studies, not only by transient elastography, but also by ultrasound-based shear wave elastography. So patients with higher liver stiffness have a worse prognosis in comparison to patients with lower liver stiffness. Not only this one single measurement of liver stiffness, which I demonstrated in previous slide, is prognostically important, but it is also important to measure longitudinally during over the time to repeat the measurement of liver stiffness. And it was demonstrated in this very important study that decrease in liver stiffness by 20% results in more than 50% decrease of risk of developing liver decompensation and liver-related death, whereas 20% increase of liver stiffness leads to more than 50% increased risk of developing these complications. So this is the summary slide, as you have heard previously from Professor Sporea. Nowadays, by using non-invasive tests, by using elastography, it is possible to stage the patients according to their risk of developing complications from chronic liver disease. For transient elastography, we use rule of 5. We start with 5 kilopascals, which is considered normal liver, and then go to 10, 15, 20, 25 kilopascals that discriminate the patients according to the presence of these complications, which I was talking previously. And if we use methods, ultrasound elastography methods that are based on ARFI principles, so point and 2D shear wave elastography, we use rule of 4 because they produce a little bit lower values of liver elasticity in comparison to transient elastography. Again, we start with 5 kilopascals, which is considered normal, and then progressively 4 more kilopascals, so 9, 13, 17, 21 kilopascals, which corresponds to 10, 15, 20, 25 kilopascals of transient elastography, and they clearly demonstrate the different risk of complications of patients with chronic liver disease. With this, I would like to conclude that elastography is a reliable, non-invasive tool for the risk stratification of patients with chronic liver disease. It might be used for rule-in, rule-out compensated advanced chronic liver disease, clinically significant portal hypertension, and viruses needing treatment. The best algorithm so far is the one that combines all 3 measurements, so liver stiffness, spleen stiffness, and platelet count. Elastography has prognostic value, and still we have data, but still more data are needed for ARFI-based method. I would like to take the opportunity to invite you to Eurozone School of Abdominal Ultrasound that is going to take place in Zagreb this December. Please feel free to contact us. Here you have contact details. This is the image of Zagreb, our center of education, one of our courses. And this is the book that was published by people from European Centers of WFUMB, European Centers of Education. It is also available for free download. Thank you very much for your attention.
Thank you very much, Ivica. Thank you to promote our book. It's a good idea to have a book of ultrasound, integrated ultrasound in clinical practice from all 4 centers European of education. I believe it's a good opportunity for all the people to know about this book, and they can download for free. And I have a short question only for you. In your daily practice, do you use liver and spleen stiffness, or you use only liver in daily practice? I don't speak about research. You make in every case liver and spleen, or only for research?
No, this depends on the clinical condition of the patient. So we usually perform liver elastography, but if we have high result of liver elastography, and especially if we have patients with NAFLD, as you saw in my presentation, for NAFLD, still liver elastography is not precise enough to diagnose the presence of clinically significant portal hypertension. So in this situation, we use also spleen elastography. Sometimes it is a little bit more demanding to perform spleen elastography, but in practice it can be done in majority of patients.
Another question about spleen elastography. How difficult do you believe it's to perform this elastography? especially for 2D. 4-point maybe it's easier, but for 2D, the feasibility, which is the feasibility in your opinion?
Yes, that is very good question. And, you know, I mean, you should also follow all the guidelines that are published for liver elastography. So the most important thing is to obtain the stable elastogram if you use 2D shear wave elastography. And, you know, different ultrasound systems have some differences. So yes, I would agree with you. It is more difficult than to perform the liver elastography, and sometimes it is more time consuming, but then finally you will have some results which could be of good clinical use.
Okay, and the last question between gastroenterologists, when you have very clear non-invasive test for portal hypertension, you fellows still perform gastroscopy or not?
This is very good question. Of course, it is not necessary to perform endoscopy. Sometimes it is performed because usually patient complain of some other problems. So in these cases, you have to perform the endoscopy. But if it is only the question of esophageal varices, if it is ruled out based on ultrasound and elastography and platelet count, it is not necessary to perform it.
Thank you very much, Ivica, because we don't
I have one question, sorry.
Yes, please.
Ivica, tell me please, how do you think the portal Doppler is useful in assessment of the cirrhosis and portal hypertension or not?
Yes, this is also a very good question, and we had a very long discussion about this with Professor Sporea in many meetings. Well, I mean, now when you have elastography, Doppler is certainly not that important in staging or assessing for the presence of portal hypertension. But of course, if you are performing the classical ultrasound, if you see the collaterals, if you see the splenomegaly in patients with chronic liver disease, then you can say, okay, this patient has clinically significant portal hypertension, and really for diagnosing it, you don't need elastography. However, when you don't see these signs, then elastography is very important. And then about the Doppler, Doppler is most important in assessing the patients with portal hypertension in a way that with the Doppler, you should try to see, are there any vascular disease condition which are the cause of portal hypertension, but not that much in staging the portal hypertension. So finding the cause and not the staging.
Thank you, Ivica. Now we go further. It's my pleasure now to introduce Dr. Sergiu Puiu. He's the director of Center of Education from Chișinău, Moldova. Chișinău is the chronologically second European Center of Education, I believe, from 2017. They have a very, very important and very good didactic activity, educational activity, and we are very happy about this. And the topics will be ultrasound assessment of the female pelvis for extra-genital pelvic pathology. Please, Dr. Puiu.
Hello, everyone. Thank you, Professor, for your introduction. And for the topics of my presentation, we need to move down in the female pelvis. Why it is so important? Everybody knows that the ultrasound is the imaging diagnostic modality of choice for the gynecological disorders. But since the female pelvis is the site of other anatomical structures, beside gynecological pathologies, ultrasound allows accurate complementary imaging for extra-gynecological disorders, providing advantage of real-time imaging where the images can be correlated with specific pelvic anatomical sites. As I told, the ultrasound can provide, in many cases, if not all cases, additional valuable data, can provide the diagnostic guidance, and in many cases, we can get the final diagnosis of other pelvic pathologies. Of course, don't forget about the POCUS, the point of care ultrasound, where the ultrasound is used as an extension of physical examination. And as I told, the images can rapidly be correlated with the patient's symptoms and state. Starting from urinary system imaging, it is a very useful tool in assessment of the bladder, distal ureters, and the kidneys. Kidneys in the case of ectopic kidneys and pelvic kidneys. And such findings, such urological findings as stones, a megaureter, many benign and malignant bladder pathologies, ureterocele can be found. Also, it is a very useful tool in assessment of the urinary obstruction caused in many cases not only by stone and lithiasis, but as advanced stages of different gynecological, bladder, or colonic tumoral pathologies. Also very important in assessment of the urinary flow in pelvic endometriosis, particularly in affecting the uterosacral ligaments. Stones, bladder stones, I mean the ureteral distal stones. The transvaginal ultrasound is a perfect tool in assessment such pathologies, particularly in cases when there are not obvious or even no urinary obstruction. The classical appearance, the reflectogenic structures, not always with shadowing, with or without urinary obstruction. Very useful sign, so-called twinkling artifact when you use color Doppler. Also, we can easily see in the, let me use the pointer. Easily you can see the edema of the ureteral meatus. Some examples, some pictures with stones located in blood diverticula. In acute pyelonephritis, when there are some mucopurulent plaques, also transvaginal ultrasound is useful. And a hint, very useful in assessment the urinary obstruction, the presence of not using the color Doppler, or if you have a very sensitive, very good transvaginal probe, you can use it without the color Doppler. You can see easily the urinary jets from the ureteral meatus, which let us to be sure there are or not the urinary obstruction. And as I told you, in affecting the uterosacral ligaments by endometriosis, you can assess the obstruction, the stage of obstruction, even the extrinsic or intrinsic, and you can easily provide the presence or the urinary obstruction. Ureterocele, meaning the dilation of intravesical ureteral segment, appearing as an anechoic structure on the posterior bladder wall. Usually with ureteral duplication, mostly in 75 cases. And as you can see, the size of the ureterocele can vary depending on the urinary flow. Also, transvaginal ultrasound can provide images of different benign or malign tumoral pathologies of the bladder. As you can see here, very rare, of course, bladder leiomyoma. Most frequently, of course, they are the bladder cancers. And it is very important to rule out the secondary involvement of the bladder by a tumor from different signs. As you can see here, it's a bladder from the rectosigmoid. And you can very easily assess the urinary obstruction in advanced gynecological as well as bladder or rectosigmoid malignancies. Cystitis. Cystitis is mostly clinical diagnosis. However, you can easily see the mural thickening, particularly caused by the edema of the mucosa and submucosa. But the advantage of ultrasound is to assess the hypertrophy of the bladder wall because of the detrusor overactivity. And for this, we need to take free measurement in the anterior wall, in the trigonal zone, and the bladder dome, and the mean being calculated. And the thickening greater than 5 millimeters, of course, in the presence of typical symptoms, is very, very informative in detection of neurogenic disorders. Bladder diverticula, appearing on ultrasound as pouches protruding on the bladder wall, often found incidentally, could be congenital or acquired, single, multiple. Of course, mostly seen in males because the outlet obstruction caused by enlarged prostatas you can see in males, but in some neurological disease, when the hypertrophy is present, we can see the diverticula in the females. Pelvic kidney, we can see such a condition when the kidney fails to climb to the anal fossa, and typically appears as a solid mass, which can be confused with a gynecological tumor, mostly asymptomatic and frequently associated with a vesicoureteral reflux. Imaging of the digestive system. Transvaginal ultrasound allows assessment of the most caudal segment of the digestive tract and provide some very valuable data regarding pelvic appendicitis, mucocele, diverticulitis, or even abscesses of the diverticulitis, colonic tumor. Of course, for the colonic tumor, the ultrasound, it is not the method of choice, but everybody who perform transvaginal ultrasound know that many cases we found incidentally rectosigmoid tumors. Of course, in some cases, it is very difficult to make a differential between bowel tumors and deep rectosigmoid endometriosis, and of course, additional expertise is required. Let's start by pelvic appendicitis, because I think appendicitis is the most frequent inflammation of the digestive tract. Of course, the ultrasound is the first imaging tool in assessment of pelvic pain when it is a suspicion for the appendicitis. And here you can see the typical ultrasound images of the inflamed appendicitis with an outer diameter greater than 7 millimeters, non-compressible, blind ending tubular structure in the right adnexal region. Increased vascularity in the appendiceal wall, and sometimes you can see appendicolits, intraluminal gases, all the sign all of us knows very well, all the sign of the acute appendicitis. One remark, because there are not many fatty tissue in the not so many fatty tissue in abdomen than in the pelvis. One of important signs that increase the echogenicity of the periappendiceal fat is not so obvious in the pelvic location of the inflamed appendices. A very rare condition, appendiceal mucocele, representing mucoid collection in the appendiceal lumen. This is a hypoechoic with low level fluid, and you can easily see in the typical appearance of the onion skin patterns with a lot of concentric layers of the very dense hypoechoic fluid. Why so important? Because it is in some cases we need to make a differential with pelvic inflammatory disease, and particularly the salpingitis or abscesses. Also, there increased risk of the pseudomyxoma peritonei. It is a malignancy, as you know. Rectosigmoid diverticula. It is a very common disease affecting 1/3, if not more, than patients above the age of 16, representing the sac-like protrusions in the intestinal wall, usually very small, and usually detected incidentally during a transvaginal ultrasound. A typical hypertrophy of the muscularis propria is evident as circumferential thickening of the outer hypoechoic layer of the colonic wall, and sometimes with the appendicolits inside, making an acoustic shadowing. A typical appearance, typical ultrasound of uncomplicated diverticular, rectosigmoid diverticular, solitary, multiple. The most important are the complications. 1/4 of individuals will develop symptomatic diverticulosis. Yeah, and here you can see some typical images with acute diverticulitis with the same appearance, the central echogenic structure with shadowing, a hypertrophy hypoechoic muscularis, and a very important sign, an increased echogenicity of the pericolic fat. Of course, with increased vascularity of the colonic wall. Mostly of patients with colonic diverticulitis will recover without surgery. However, the remaining may have some complications such as abscesses, fistulas, obstruction, or even perforation. Here you can see very clear, very good, in my opinion, images with abscesses. And here a short clip with the same thing with abscesses as complications of the acute diverticulitis. Moving forward, ischional abscesses of the same as not only as complications as acute diverticulitis, but caused by many different causes, and fistulas. And fistulas, here you can see clearly and easily a channel with the inner orifice and the outer orifices. Colorectal inflammatory process, I mean the distal segment, the rectosigmoid, and here you can see the typical ultrasound images of inflamed sigmoiditis with increased thickness of the wall, particularly by the submucosa. Here you can see the muscularis, the submucosa, the mucosa. You can see here the submucosa is increased, is thickened as high as almost 7 millimeters, increased vascularity, and of course the secondary reaction of secondary inflamed lymph node. Typical images of the inflammatory process, which are available not only for the sigmoid inflammation, but the entire colon, and not only colon, the entire digestive system. Bowel tumors. As I told, the ultrasound is not the method of choice in assessment bowel tumor, but everyone knows that many primary and secondary tumors are incidentally findings on transvaginal ultrasound. However, if you have a very high frequency endovaginal probe, you can assess the invasion of the neighboring organs and tissues, and you can use it for the local staging of the tumors. And it is very useful in assessment of rectosigmoid stenotic neoplasm. The appearance varies from the segmental mural thickening or as hypoechoic or heterogeneous intral extraluminal solid masses. You can see here some pictures, and the upper one images are demonstrating sigmoid polyp, considered a benign condition, but it is a precancer, as seen as a round, well-delimited structure. And in these images, you can see an exophytic and endophytic malignant neoplasms in a short clip, very nicely demonstrating an exophytic tumor invading the neighboring structures. Peritoneal carcinomatosis, the state when the tumor spreads to the peritoneal serosa and structure everywhere in the abdominal cavity, but particularly here the pelvic the pelvic cavity. Most common conditions are colonic, rectal, ovarial, stomach, or appendix cancers. And this invasion is considered a clinical stage 4 with a course of with a poor prognosis and short lifespan. You can see here the nodules of peritoneal carcinomatosis. Epiploic appendigitis, it is an emergency. Epiploic appendage, here you can see a normal appearance of the epiploic appendage, a round, mobile, and painless structure. The inflammation is caused even by torsion or thrombosis of the epiploic appendage, and it is associated with a severe, very severe and acute abdominal pain. And on ultrasound image, you can see a round, non-compressible, very painful when I press with the tip of the transvaginal probe, very, very painful, without color flow. And it's, I hope you can see here an echogenic rim around the inflamed epiploic appendage. Pelvic congestion. Pelvic congestion mostly causes by pelvic varicose veins. It is a cause, in most cases, a cause of chronic pelvic pain, presented more than 6 months. However, it could be reported in asymptomatic women. The causes are multifactorial. There are mechanical causes or hormonal issues. As ultrasound appearance. For the positive diagnosis, we need to see at least 4 ipsilateral pelvic veins varying in caliber, but at least one greater than 4 millimeters, or one ovarian vein greater with a diameter is greater than 8 millimeters. Also, typically appearance, a lot of tortuous tubular structures, and also you can see in the uterus the dilated arcuate veins, usually greater than 2.5 millimeters. Sometimes you need to make differential with hydrosalpinx, for example, because it is very easily, can be easily confused with a hydrosalpinx, and as usual, the color Doppler help us to differentiate and to indicate the tubular structure, the vascular structure of the dilated vein. For the neurogenic imaging, these tumors or pathologies are very rare, and in many cases they are benign schwannomas or neurofibromas. As you can see on the left picture, here is the uterus, and posteriorly a huge, well delimited solid mass. More frequently, you can see tile of cysts, or literature you can find them as meningeal or perineural cysts. Why it is important? Because in some cases we need to make a correct differential between the tile of cyst and the hydrosalpinx, and the anterior location to the piriform muscle and the origin from the spine can help us to make a correct differentiation. And finally, some words about the deep endometriosis. Of course, it's a gynecological pathologies, but since in many cases the deep endometriosis affects other than gynecological structure, I will tell you about this some words, not some. Endometriosis can be found everywhere in the female pelvis, most commonly in the uterosacral ligaments, the rectus sigmoid, the bladder wall, and in the uterovesical pouch and the pouch of Douglas. A typical appearance for deep infiltrating endometriosis is the hypoechogenic nodule. And depending which compartment is affected anteriorly, I mean the bladder, or the posterior compartment, I mean the rectal sigmoid or uterosacral ligaments. These nodules are found in the muscularis, in the submucosa, or even mucosa if you mean the bladder involvement, as you can see here. In the upper images, you can see the abdominal equivalent for the transvaginal ultrasound. And when we cannot prove the natural mobility of the bladder and the uterus, when the uterine corpus don't glide freely against the bladder, we call that this uterovesical pouch is obliterated. The limited mobility is one of the secondary important signs in the assessment of the deep infiltrating endometriosis. And when we speak about the rectosigmoid affection, the nodules usually affects only the serosa muscularis, very rare the submucosa. And I think, in my opinion, is a very important differential criteria against the rectosigmoid neoplasms. All these things are associated with a chronic pelvic pain with this increase during the menstruation. And as I told you, we can assess the mobility, the sliding sign when it's negative, when the natural mobility is affected, and the uterus don't glide freely against here in the posterior compartment against the rectosigmoid. So in conclusions, the female pelvis is a complex anatomical region, and of course we need to assess not only a gynecological problem, particularly when the female addressed to the doctor with pelvic pain. Because it allows a very, very accurate complementary imaging for other extra-gynecological disorders. And from my point of view, it does not require many additional time, very little additional time. And in many cases, we can get the final diagnosis or focus on the differential. And of course, all of this allows prompt and appropriate management of patients with female patients with the pelvic pain. So that's all I would like to tell you. If there are any questions, please don't hesitate to ask.
Thank you very much. Thank you very much. Very nice presentation, like usual, and the image are wonderful, incredible, nice image. From my point of view, like gastroenterologist, I enjoy a lot about your image. Because we are out of time, we don't have time for question, and I asked to the last presenter to try to be strict in 20 minutes to finish in our 2-hour time of our meeting. And it is my pleasure to introduce now Xue-ying from Center of Education in China, and the topic is about echocardiographic assessment of cardiac function, a practical pathway based on Chinese guideline. Okay.
Oh. Sorry, please. Okay, I need to share my screen.
Roxana, you is the master now. I believe you can approve the.
You can begin screen sharing. It's the green button.
I see. Thank you.
Down.
Okay. Well, thank you, Professor Ioan Sporea, for your lovely introduction.
Perfect.
Okay, can I begin now?
It's perfect. Please.
Hello, everyone. I'm Zhou Xue-ying from Tangtu Hospital, Xi'an, China, and I feel greatly honored to join this COE meeting and share with you the echocardiographic assessment of cardiac function. Echocardiography provides dynamic real-time visualization of the heart. Its strength of being non-invasive, widely available, and highly reproducible make it one of the most essential imaging modalities in cardiology. Echocardiography goes far beyond simply taking pictures of the heart. What really makes it powerful is its ability to dynamically measure how efficiently the heart is actually working. And comprehensive cardiac assessment is comprised of two integral parts, systolic and diastolic function. Systolic function refers to the heart's pumping capacity, how efficiently it ejects blood, and diastolic function refers to its filling capacity, how efficiently it relaxes and refills. When facing a heart failure patient, the first question we must ask is the cardiac pump strong enough? And assessment of systolic function can answer this core question. It translates vague concepts of this cardiac dysfunction into quantifiable, actionable guidance. Assessment of systolic function can be used for diagnosis and classification of heart failure. It directly distinguishes whether the heart failure is due to reduced ejection fraction, which is a pump problem, or due to preserved ejection fraction, which is a filling problem. Second, for risk stratification, it serves as a powerful prognostic indicator. Lower systolic function means higher mortality risk. And third, for guiding treatment and monitoring efficacy. Some treatment strategies for improving heart failure are based on systolic function measurements, and the change of systolic function can also be used to evaluate treatment efficacy. We will first talk about left ventricular systolic function. For evaluation of systolic function, the ejection fraction is currently the most widely used method. It represents the percentage of blood pumped out from the left ventricle relative to its end diastolic volume in each cardiac cycle. To calculate LVEF, we must first measure these two parameters, end diastolic volume and end systolic volume. And these parameters can be obtained from M-mode echocardiography or modified Simpson's method. The assessment of systolic function via M-mode relies on linear structural measurements, assuming that left ventricle is a prelate ellipsoid. The primary advantage of M-mode is its convenience and time-saving nature, making it one of the most commonly used measurements techniques. However, its limitations are also evident for patients with ventricular deformations or segmental motion abnormalities. This method cannot actually estimate left ventricular volume. And therefore, M-mode echocardiography is generally recommended for assessing left ventricular systolic function in patients with relatively normal cardiac anatomy. The modified Simpson's method can be performed by tracing the endocardium in apical 4-chamber view and apical 2-chamber view and measuring the length from mitral annulus to apex. The LV volume is calculated by summing volumes of multiple evenly sliced discs. The modified Simpson's method is applicable to left ventricular cavities of any geometric shape and demonstrate excellent reliability in assessing patients with left ventricular wall motion abnormalities. Its limitations include longer measurement time and occasional suboptimal endocardial border delineation. The method is dependent on the operator's technical proficiency and personal experience. It's currently recommended for measuring left ventricular volumes to calculate left ventricular ejection fraction. LVEF less than 52% in men and less than 53% in women indicates abnormal left ventricular systolic function. LVEF between 40% to 52% indicate mildly reduced systolic function. LVEF between 30% to 40% indicate moderately reduced systolic function. LVEF less than 30% indicate severely reduced systolic function. Stroke volume is another quantitative measure of pumping function. It refers to the volume of blood ejected by the left ventricle per cardiac cycle. It can be calculated from the end-diastolic volume and the end-systolic volume obtained in the aforementioned examinations using the formula SV equals EDV minus ESV, or alternatively measured using Doppler echocardiography based on blood flow across the aortic valve annulus. The normal stroke volume ranges from 33 to 78 milliliters per beat in males and 29 to 63 milliliters per beat in females. Peak systolic mitral annulus velocity is another indicator for systolic function. It can be measured by placing the Doppler sample volume at the septal or the lateral side of the mitral annulus. This parameter demonstrates good agreement with LVEF. The normal value of S prime should exceed 5 centimeters per second. Global longitudinal strain is calculated using dedicated LV strain software to track the LV endocardial wall. It's a more sensitive index than of myocardial systolic function than ejection fraction and provides earlier detection of myocardial diseases in the setting of a normal ejection fraction. Impaired GLS is common in patients with heart failure with preserved ejection fraction, indicating subclinical LV dysfunction. Assessment of GLS requires dedicated software package, so it's not applicable in all institutions, and the values may vary between vendors, thus the result is not interchangeable. Currently, the lower limit of normal GLS is minus 17% in men and minus 18% in females. For assessment of right ventricular systolic function, we can use fractional area change, which is measured in the apical four-chamber view focused on the right ventricle. It's calculated as the end diastolic area, the difference between end diastolic area and end systolic area divided by end diastolic area. An FAC value less than 35% indicates impaired right ventricular systolic function. Tricuspid annular plane systolic excursion TAPS is another indicator for systolic function of right ventricle. It is measured in the apical four-chamber view focused on the right ventricle and presents the longitudinal contractile function of the right ventricle. A TAPS value less than 16 micrometers indicate impaired right ventricular systolic function. After checking the pump, we must ask another question. Can the heart feel properly? Assessment of diastolic function answers this equally vital question. It uncovers hidden dysfunction behind a normal pump. It can be used for detecting acute heart failure, which is essential for diagnosing heart failure with a preserved ejection fraction, and can plainly explain the symptoms in patients with preserved ejection fraction. Assessment of diastolic function also serves as the early warning sign since it appears before systolic decline. For dynamic profiling, the assessment of diastolic function can provide a non-invasive pressure gauge for estimating left atrial pressure and can help, which is critical for guiding precise diuresis to avoid under or over treatment. For revealing long-term sequelae, chronic diastolic dysfunction can cause left atrial enlargement, which is a key marker for atrial fibrillation and stroke risk, and can also drive secondary pulmonary hypertension. Diastolic function can be measured using pulse wave Doppler at transmitral valve inflow. The PW Doppler sample is placed at the mitral valve leaflet tips at the apical four-chamber view, and we can obtain peak E velocity and peak A velocity, and we can also calculate E to A ratio. The velocities of transmitral inflow reflect the LA to LV pressure gradient. Tissue Doppler imaging at mitral annulus can also be used to evaluate diastolic function. The sample volume is placed at septal and lateral insertion site of the mitral leaflets at apical four-chamber view, and we can obtain E velocity, E prime velocity, which indicate peak early diastolic velocity, and A prime velocity, which indicates peak late diastolic velocity. And we can also calculate E to E prime ratio. The E prime velocity is an index of left ventricle relaxation, and E to E prime ratio can be used to predict increased left ventricular filling pressures. The third index or third parameter for ventricular diastolic function assessment is left atrial volume index. It's measured in apical four-chamber view and apical two-chamber view. From each view, we trace the LA area and measure the LA length from the center of the mitral annulus to the center of superior LA wall. Left atrial volume reflects the cumulative effects of increased left ventricular filling pressures over time. And left atrial volume index is left atrial volume divided by body surface area. We can also use tricuspid regurgitation to evaluate diastolic function. We can measure the peak tricuspid regurgitation velocity to calculate pressure gradient between right ventricle and right atrial. With this pressure gradient, we can obtain right ventricular systolic pressure, which can be used to estimate pulmonary artery systolic pressure. And in the absence of pulmonary diseases, increased pulmonary artery systolic pressure suggests elevated left atrial pressure. The four recommended variables for identifying diastolic function and their abnormal cutoff values are annular E prime velocity, septal E prime less than 7 centimeters per second, and lateral E prime velocity less than 10 centimeters per second. Average E to E prime ratio greater than 14, LV volume index greater than 34 milliliters per meter squared, and peak TR velocity greater than 2.8 meters per second. LV diastolic function is normal if more than half of the available variables do not meet the cutoff values for identifying abnormal function, and LV diastolic dysfunction is present if more than half of the available parameters meet these cutoff values. The study is inconclusive if half of the parameters do not meet the cutoff values. Currently, assessment of right ventricular diastolic function is not a routine part of the echocardiography, so it's not within the scope of today's discussion. And that's all for my presentation. Thanks for your attention.
Thank you very much. Very nice presentation, very clear presentation. I don't know how many of people that attend the meeting are involved in echocardiography, but for people that pay attention to echocardiography was interesting one. What do you believe about the integration of module of artificial intelligence now inside our machine? Because many of these parameters are made automatically by artificial intelligence. How you feel about this?
Sorry, can you speak
yes,
slowly?
Artificial intelligence in echocardiography. What do you believe about this field? Because it's developed a lot.
Do you mean the parameters are too
yes,
many?
The parameter can be made automatically by artificial intelligence. The doctor is necessary to make many measurements. Then it's a very fast process to have this parameter.
Yes, the artificial intelligence, I believe it will play a significant role in echocardiography assessment because it unifies the standardization. Sometimes if we the same patient, but different sonographers, they can have the different conclusions. And so I think with the help of AI, the standardization will be
more precise, more precise. Okay. Thank you very much. Is there other question for other speaker maybe from the audience? If not, I believe was an interesting meeting, despite the number of participants is not so high that we expected. You must know that more than 3,000 people were registered, but many of them, they are not online for this meeting. Maybe the recorded meeting will be available in the website of WFUMB, I believe, Lynn.
Yes, correct. In the next few days.
Wonderful, wonderful. Maybe we can continue to promote these webinar, and people that are not able to attend the meeting online, maybe they can have this later on. I like to thank to everyone, and I believe we must continue to have such interesting meeting, and this bridge between Asia and Europe, I believe it's good for unification of our training in and practice in ultrasound. And I wish you a nice evening, afternoon, matter in which part of the world you are in this moment. Thank you very much, and bye-bye.
Thank you. Bye-bye.
Bye, bye, bye. Thank you.
Bye-bye.
Bye-bye.
Bye, everyone.
bye-bye.
Bye.
Bye-bye.